Hello, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to today's ANAwareness Week presentation on cognitive rehabilitation with Dr. Megan Sherod from the University of Central Florida. We'll begin shortly, but first a couple of quick items. Captions are available for this presentation at the bottom of your screen. For those joining us on Zoom, you can submit questions to be answered at the conclusion of today's presentation by using the Q&A function also at the bottom of your screen. Please note, while we are simulcasting this webinar to Facebook, we are unable to monitor questions in that comment section live. This presentation is part of our ANAwareness Week, so make sure you stay connected to the ANA through our social media pages and anausa.org/awareness. Our website is also a great place to view resources and videos, study clinical trials, connect with others, and more. A special thanks to all of our partners who help make this week happen. So now, Dr. Sherod, if you'd like to turn on your camera and introduce yourself, we can get started.
Hi, everyone. Thank you so much for spending a little bit of your Wednesday with me. We'll go ahead and get started. I'm Dr. Megan Sherod. I am a neuropsychologist and clinical professor at the University of Central Florida. I'm going to go ahead and share my screen here, and we'll get started. All right, so I wanted to start with just a little bit of neuroanatomy. So the ANVS is going to sit right where the cochlear nerve and the vestibular nerve come together to form the auditory nerve. And it also sits near the facial nerve. Because of its location, the ANVS can cause different cognitive issues depending upon a lot of different factors. So the size of the ANVS can play a part in the different cognitive side effects. The type of surgical approach can play a part, radiation can play a part, and so I'm going to cast a wide net today to try to capture as many cognitive effects as possible, but please keep in mind that what I am discussing may or may not represent your journey, and I would welcome any questions that you have about any particular symptoms that you're experiencing at the end of today's talk. So these symptoms can occur prior to treatment, but most of them are more likely to occur following treatment. So you might see deficits in auditory and visual attention, or deficits in visual spatial abilities, deficits in sound localization, changes in your balance and your vestibular functioning, and or deficits in your muscle memory. And I'm going to go through each of these now. So one of the first things that people with ANVS may notice is a change in their auditory attention. And so to be able to attend to something, we have to, at least something that we're listening to, our verbal attention, we have to be able to actually hear it. And so if you are distracted by tinnitus, or if you're distracted by anxiety or nausea, headache, that can make it really difficult for you to actually get the information in, and that's attention. And then if you can't attend to something, you can't really be expected to remember it. So if a person experiences disruption in auditory attention, either because they can't hear it or because they've been distracted by something else, then the auditory information does not make it into memory. So if attention declines, then so does memory. You also might experience some changes to your visual attention, or your attention for things that you see. So visual attention is oftentimes disrupted in ANVS due to anxiety, and specifically because we are constantly looking for danger areas in our environment that could affect balance and movement. So a lot of times we'll experience something called gaze anxiety, which is that we look to where we're afraid. So for example, if you are walking and you're walking outside and you're concerned about tripping, or if you're walking someplace with uneven ground, then most likely you're looking maybe 3 to 4 feet ahead of you on the ground. And because of that, you might miss a bicyclist or a runner who's running right at you, and this can cause a collision. And so if we are sort of tuning out things that seem irrelevant to us just getting from point A to point B, then we experience disruption in our visual attention. And because of that, visual information doesn't make it into memory. Now, ANVS can also affect visual spatial abilities. So visual spatial abilities are our abilities to scan an object or to scan an environment with our eyes and then organize that information. And so this can include depth perception. It can include localizing objects and ourselves in space, so knowing where we are in comparison to a tree, to a building, to where we are inside our dwelling. And this goes beyond eyesight and whether or not vision is 20/20. A person can have 20/20 or near perfect vision, but not be able to put a puzzle together, not be able to parallel park, not be able to organize a checkbook or to catch a ball or to hit a ball or to play pool or billiards or to draw or to do geometry. Those actual actions are visual spatial abilities, our ability to take information in with our eyes and then to make sense of where things are in space and then to react to where those things are in space. So how we determine depth and organize information in space is controlled by parts of the brain that are very close to where the ANVS occurs. So this results in difficulty with misreaching, so overreaching or underreaching for objects, misstepping, either not stepping enough to go up a step or maybe not stepping far enough to go down a step, and then otherwise successfully negotiating spaces. So this is a picture of a brain as if we're looking through the left ear. And so as you can see, on that bottom part of the brain, that's our what pathway. That's the temporal lobe. And that is sort of our memory for things that we see and our ability to organize things that we see. And then you'll see sort of up the kind of the back side, you'll see the where pathway. And what we're looking at is where the soccer ball is our occipital lobe. And that is important for vision. And then where the compass is our parietal lobe. And that is, that does a lot of things, but in this context, it helps us locate objects in space. And so where the ANVS sits is right there, kind of where these two pathways tend to meet. And so that makes it really difficult for us. Sometimes it slows down information going from one pathway to the other, and that's what disrupts our ability to make sense of where things are in space and our visual spatial abilities. Another aspect is sound localization. This can be affected. Our brains determine where a sound is coming from via a process called sound localization. So if one or both ears experience hearing loss, it can become very difficult to determine where a sound, such as a voice, a beeping smoke detector, the ding or ring of a cell phone, where those things are coming from. Hearing loss affects our ability to appreciate the timing of sounds, meaning that sounds reach the cochlea, which is a part of the brain that's important for processing sounds and for turning sounds into neural energy that our brain can understand. And so hearing loss means that sounds reach the cochlea at different times. So this is a picture of how we hear. So you can see there we have that fleshy part of the ear, that's the pinna. And that's the part of the ear that captures sound, and it funnels it. It funnels sound down the ear canal to the eardrum. And then sound waves hit the eardrum, which causes vibrations. The small ear bones that are known as the ossicles, and here you can see the malleus, the incus, and the stapes, these vibrate as a result. And the vibration of the bones cause fluid in the cochlea to be moved like a wave. And depending upon the frequency of the sound, so whether it's a high pitch or whether it's a low pitch, the wave will travel to a specific part of the cochlea. And hair cells along the inside of the cochlea begin to move, kind of like wheat blowing in the wind. And they brush against the roof of the cochlea. And it's at that point that changes, that brushing of the little hair cells changes sound energy into electrical energy. And that electrical energy then moves along the auditory and vestibular nerves. The AN and VS And the treatment can disrupt the sound's ability to be transmitted from the ear to the part of the brain that analyzes and comprehends sounds. This is where the ANVS is. And so it can slow down the transmission of the sound to the brain. And so this oftentimes might result in a person being able unable to localize sounds because the sounds are hitting the brain or being processed by the brain at different times. Another thing that can be disrupted is vestibular function. And your vestibular function refers to our balance, our muscle memory, and our body's ability to keep us upright. And so in order to know where our body is in space and to successfully move through our environment, we have to have an adequately functioning vestibular system. And our vestibular system is made up of several structures. So there's two structures that are in our inner ear, the part that I just showed you, and these are the semicircular canals and the otolith organs. The semicircular canals and the otolith organs send information about our head's position, whether it's moving up and moving down, whether it's moving side to side, or whether it's accelerating or decelerating. And it sends this information to other parts of the brain via the vestibular nerve. If an ANVS is present, the vestibular nerve can't send this information as efficiently if it sends it at all. The vestibular nerve is going to send information to the spinal cord, the muscles that control the eyes, the cerebellum, which is important for movement, muscle tone, and posture, and the motor cortex, which is important for coordinated movements. And so it's this system that's responsible for feeling dizzy after a person's been spun around. In order to stop feeling dizzy, our eyes will search for a stable fixation point so that there's a stable image on the retina when the head moves. And this is going to be an important point that I'm going to come back to in just a second when we talk about, okay, what are some tips for navigating any of these cognitive effects? What happens when the vestibular system is disrupted is that messages about the position of the head and the body in space are not seen efficiently, if at all. And our brain is essentially unable to locate its position in space, and it can't make sense of movement, and that can lead to our body feeling wobbly. Because of these lags in vestibular information being received by other parts of the brain, because the processing speed might be slower on one side of the brain versus the other, a person can develop a persistent dizziness, and that can lead to nausea and vomiting. When the inner ear is disrupted, the brain's going to depend on other structures like the eyes to determine its location in space. And this can lead to the eyes constantly scanning the environment in order to tell the brain where the body, where the head is. And that can lead to visual inattention to other items in the environment, particularly items that are closer to the body. So again, that gaze fixation I talked about earlier. Another thing that can be disrupted is muscle memory. And deficits in muscle memory have a direct effect on our quality of life. So when the vestibular system is affected, our body is going to struggle to adjust the posture, muscle tone, and positioning in order to keep us upright to complete a motor task. And so, for example, if we place our foreheads on the grip of a baseball bat and we walk around or we spin around the bat, then attempt to walk a straight line, it can't be done. So when we don't know where our bodies are in space, we can be easily thrown off balance while attempting tasks and activities. And that can be things like trying to swing a golf club, trying to swing a baseball bat, trying to throw a bowling ball, trying to dance, trying to ride a bicycle or a horse, trying to run, skip, or jump. And it's going to be more difficult the further away from our body those tools like a golf club or baseball bat or bowling ball are. So, if any of this has described something that you have been experiencing, I want you to know that these are real things. These are valid things. These are real cognitive side effects that you may have experienced prior to treatment, but that you most likely have experienced maybe a little bit more following treatment, and that's both treatment with surgery, or radiation. So, the best approach to cognitive rehabilitation in ANVS is an individualized approach. No two people are going to experience exactly the same changes in cognition. And so cognitive rehabilitation is typically designed to retrain or reorganize functions attributed to the parts of the brain that were affected. But it is important to note that cognitive rehabilitation cannot overcome a sensory deficit, such as single-sided deafness. With sensory deficits, accommodations are going to be the only option. So I put together a few tips for today just to get you started. So if you are experiencing difficulty with auditory and or visual attention, and because of, like I mentioned, when you disrupt attention, you're going to disrupt memory. If we can't attend to it, we can't be expected to remember it. Then I would encourage you to write down or video audio record important instructions, things that need to be remembered. Set your computer or smart device to provide date and time alerts and reminders for things like appointments, meetings, birthdays, other significant events. Utilize checklists, and this could be writing them in a little notebook or using an app on a smartphone. You can use these for organizing things, planning things, executing tasks that you need to complete. I would highly encourage you to have healthcare providers print out office notes for you before you leave their office, or ask them if you can record them as they are giving you instructions, whether that is in a voice memo or whether that's recording video. Keep a small notebook with you for you to write notes, or for others to write notes for you, or keep notes organized on a smartphone. Practice with games designed to develop or improve attention and memory. Many of the games that I grew up with in the 70s and 80s are things that really can help us now. These, without really knowing it, a lot of the cognitive developmental tasks that we learned years ago can help us now. So things like the memory game Simon, that's the one that has the 4 colored discs that will beep at you and will also show you a pattern in the colored lights. So being able to follow that can help you practice with both visual attention and to some extent auditory attention. There are some online brain training games, and these are fine, but I'm a big proponent of being able to do things in 3-dimensional space. So something that you can see, something that you can hear, something that you can touch, things that are more like the memory game, bingo, musical chairs, so things that have a much more active component than just you and the computer. But if online brain training games are the only thing that you've got, they're not going to hurt you. They just might not be as helpful as some of these other things that you can do in 3-dimensional space. Learning new song lyrics, chain games. And chain games are those games where one person starts a story and each subsequent person adds one piece of new information to that story. This is a great way to get family members who want to be helpful. This is a great way to involve them in your recovery. The game telephone, repeating and recalling a list of words like a grocery list, listen to a new story, repeat the story back with as many details as you can remember. And it's very easy for me to sit here and see this and very difficult to do, but practice as much as you can. I would say 15 minutes at least in the morning and 15 minutes at night, and give yourself time. The brain is the most complex structure that we have in the body. And so it's going to take a minimum of 6 months for you to start recovering some of these, particularly following surgery. If you are experiencing difficulty with auditory comprehension, auditory comprehension is our ability to understand what other people are saying to you or being able to effectively follow a conversation. And it's typically affected by the loss of hearing and or tinnitus. So if other people are speaking too quickly, it is perfectly acceptable to ask them to slow down or repeat themselves. If that's something that you don't feel comfortable doing, but you feel comfortable having a smartphone out, then I would encourage you to have one of the transcription apps. So you can have Google Live Transcribe, use Otter, Ava Live Captions, Hearing Helper, Live Caption, so that you can hold it while the person is talking and it will transcribe for you in real time and pretty quickly what the person is saying so that you can continue to be part of the conversation. I know that many of the folks that I have worked with over my 20-year career, many have told me that they felt that they were being talked around or that they were left out of conversations. And my goal is to help you find your way to work with your loved ones and help ensure that they continue to keep you a part of the conversation. Request closed captioning whenever and wherever possible. If closed captioning is not possible for an online video or podcast, then Tube ONAI can summarize the video for you. And then if you're using FaceTime, you can turn on the live captions. So to do that, you just start the FaceTime call, you press the info key, turn on live captions, and press done, and it will caption your conversation with your loved one. If you're experiencing difficulty with your visual spatial abilities, now I do always put in the caveat that if you're like me and you were never able to parallel park, then this will probably not help you. But if you were able to do these things before, if you had good visual spatial abilities before your ANVS, and then had a little bit of a disruption there following ANVS surgery or radiation, then some of these things might work for you. But if you couldn't do it beforehand, these are probably not going to help you that much. For math-related items, I suggest using graph paper to organize all computations. Graph paper isn't just for geometry. It can be very helpful in helping line up columns to do addition, subtraction, division, multiplication. For misstepping and misreaching, sometimes covering the eye on the same side as the tumor can help. And again, that helps create a stable image on the retina. For difficulty with eyes skipping words or lines while reading, utilize a reading window. And this is just, you can take a simple Post-it and just cut out a little square in the middle of the Post-it and use that to follow along. You put that down over what you're reading, and that way only one word comes into the window at a time, and it can make it a lot easier for you to read so that your eyes are not jumping around the page. You can practice again with games designed to develop or improve visual spatial abilities like Jenga. That's a great one for, especially if you have younger children or grandchildren or nieces and nephews that really want to be helpful and want to be involved in your therapies. You can say that this is some of your cognitive homework and ask them to play Jenga with you so that you can help. That will help with your visual spatial abilities. 3D puzzles are great. Simon, that's what I was talking about earlier with the discs, the color discs. Operation, pick up sticks, Legos, Sudoku, hidden objects, coloring books. These are all great ways to just spend 15 minutes in the morning, 15 minutes in the evening to keep your mind active and kind of practicing these visual spatial abilities. You know, these games that we played during childhood are really a great way to engage the family and friends in your at-home cog rehab activities. So I highly encourage you to discuss this and get your family and loved ones involved. Jigsaw puzzles are great, but I would recommend beginning with a simple 50-piece puzzle and work your way up to more complex puzzles with more pieces. So depending upon how long it takes you, if you can do a 50-piece puzzle in one sitting, fantastic. Then I would challenge you to go to a 100-piece puzzle and then to 200, 250. If it takes you a little while longer, if you need a few days to do that, you know, I would say if you could maybe do a puzzle a week, with the exception of if you work your way up to a 5,000-piece puzzle or a 3D puzzle, give yourself a little more time to do those. Paint by number is great. It assists with both visual spatial abilities and it helps with mood. And again, practice and time. These are things that need to be practiced daily. Just like a physical therapist and occupational therapist would recommend that you do daily exercises for your arms and hands and legs, I'm going to recommend that you do these daily exercises for your brain. If you are experiencing difficulty with sound localization, if the sound involves another person, then ask them to be specific. So, you know, instead of saying "I'm in here," if you're walking into your home, ask them to say "I'm in the kitchen" or "I'm in the upstairs bedroom." If you're trying to locate a cell phone, turn on blinking lights and haptics to try to engage as many different sensations as possible and to assist with location or notification of a call or a text. If this sound involves an animal, such as a pet, particularly if you have animals that like to walk around or like to follow you at night, I would highly recommend getting LED pet collars. Again, with balance issues, the last thing that we want is for somebody to trip over a pet at night, especially one that you are having a difficult time hearing. So highly recommend LED pet collars. If sounds are too loud, this is something called phonophobia. Soft construction grade disposable earplugs. You can buy those at just about any home improvement store, or noise canceling headphones. For some people, sound machines that contain a particular type of noise can be helpful, and I would encourage you to find the appropriate noise color for you. There are things we used to just hear about white noise, which was that staticky noise that we used to get way back when the television would go off at 11 o'clock at night. But there's actually different colors of noise, and once you listen to a noise, you'll find some that will um, feel very calming for you, and I would encourage you to find those. And you might find some that you find more irritating, and I would say stay away from those. You can go on YouTube and just search for brown noise, pink noise, blue noise, yellow noise, in addition to white noise, but find the appropriate noise color for you. It works for some people, and there has been a little bit of research that's done on this to say if you can find the color noise that matches the pitch of your tinnitus, that can be very helpful in quieting the tinnitus. But it does not work for everyone. So if you try it and it doesn't work for you, then we'll try something else. Low volume relaxing music, particularly instrumental music, can help in reducing the frustration and the disruptiveness of the tinnitus. I would encourage you to have a whiteboard in your home, especially if you live with other people, and set each day or part of the day to different noise levels based on your threshold at the time. So if you are having a day where most noise are bothering you, then I would say, write on the whiteboard marshmallow toes and whispers because you need it quiet. Something like dog paws, inside voices for moderate noise. And if you're not feeling particularly sensitive that day, then galloping horses and outside voices. And again, this indicates to your loved ones sort of how you're feeling that day, or it can even be part of the day, and so that they can be mindful of what they can do to help support you. If you are experiencing problems with vestibular functioning, so this could be dizziness, vertigo, nausea, vomiting, persistent balance issues are common before and after treatment. Vertigo is common before and after treatment. And nausea secondary to vertigo is also fairly common before and after treatment. Medication might help with nausea and vertigo, but I would encourage you to please speak with a healthcare provider about whether medication is an option for you. The biggest issue is that a lot of anti-nausea medications, they can increase the risk for fall just because they can be sedating. So please talk with your healthcare provider about medications if that's something that you're interested in pursuing. Consider seeking an evaluation and treatment from a certified vestibular therapist. Certified vestibular therapists are typically physical therapists, occasionally occupational therapists, but they're physical therapists typically who have additional specialization in vestibular disorders. So all certified vestibular therapists are going to be physical therapists or maybe occupational therapists, but not all physical therapists or occupational therapists are certified vestibular therapists. So please check out their credentials and see if you need assistance. Please feel free to reach out to me. And again, practice, 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 and show yourself some grace, give yourself some time. If you're having difficulty with muscle memory, the last thing that we want you to do is to give up your beloved activities. And so we can adapt pretty much every activity. So practicing, relearning to do your beloved activities or modify the activity to fit your level of ability. So chair exercises, if you used to be a dancer, there are still chair exercises. There are dances that can be done using props to help you with your balance. Modified golf, modified bowling, modified cycling. There's disability personal training. This is a certified personal trainer that specializes in working with people with disabilities, chronic illnesses, or older adults with mobility issues. And again, practice and time, but continuing to be involved in the activities that you love. That is the goal, is to get you back to as close to the life that you had before ANVS as possible. For outpatient individualized cognitive rehabilitation, I would encourage you to start with a neuropsychological evaluation with a neuropsychologist to determine your cognitive strengths and weaknesses. Some neuropsychologists that perform evaluations offer cognitive rehabilitation, or they're affiliated with the Cog Rehab Center. But if the neuropsychologist is not affiliated with the Cog Rehab Center and doesn't offer Cog Rehab services themselves, then I would encourage you to ask for a referral for Cog Rehab. But be very careful because not all programs that call themselves cognitive rehabilitation programs are reputable. And then again, when in doubt, please feel free to reach out to me for a list of reputable programs. Please remember that all neuropsychologists, such as myself, are clinical psychologists with additional training and specialization in neuropsychology, but not all clinical psychologists are neuropsychologists. It's sort of like the difference between your primary care physician and your neurologist, right? So your neurologist is a medical doctor who has additional training. And your primary care physician is also a medical doctor, but who doesn't have that additional training in neurology. So the two most common questions that I get are, does ANVS cause dementia? So dementia is an umbrella term, and it's really it's actually not very difficult to meet the criteria for dementia. It means only that a person is experiencing problems with memory and one other area of cognition. ANVS removal can have an impact on auditory attention and consequently auditory memory. But we don't diagnose dementia when the cause of a memory issue is a sensory deficit. So I would not diagnose somebody who is legally blind with dementia if they did not perform well on a visual memory test. And I would not diagnose someone who has single-sided deafness with dementia if they did not perform well on a verbal memory test. How do people living with ANVS socialize when tinnitus affects the ability to communicate? Well, your level of comfort is going to vary from day to day, and that's okay. Recognizing your comfort level and communicating this to others really is key. If the tinnitus is overwhelming, then maybe texting is going to be best for that day. If you want to attend a large social gathering and the noise is too loud, then bring earplugs, headphones, and maybe a small notebook to write in to exchange notes with people. If you feel comfortable with small sorts of noise, then I would encourage you to do 15 minutes on and 15 minutes off. So 15 minutes on means that you engage with others, and then you excuse yourself to go to someplace quiet, and you spend 15 minutes just sort of decompressing and letting your system kind of reset itself and calm itself. And then when you feel ready, you go back out and you do another 15 minutes on and 15 minutes off. If at the end of those 15 minutes off, you still need a little more time, then give yourself more time. You are the expert on you, and you know what's going to be best for you. So if you have any questions, please feel free to email me. Otherwise, I'll go ahead and stop sharing my screen, and I'll ask Matthew if there were any questions.
Yeah, thank you so much, Dr. Sherod. You always give such great insight to the cognitive side of acoustic neuroma and things of that nature. So we appreciate it. We know that you've been part of many of our support groups in the past and Awareness Week in the past as well. So thank you for your time. First of all, I see someone asking if the slides will be available after the presentation. We are recording this presentation and will be up on our video library and our Awareness Week page. And as well as Dr. Sherod's email was there at the end as well that you can reach out to her for questions also. So we'll go ahead and get to some of the questions that we've had come in. This patient asks that they are 5 months post-operation. Why might they be having so much trouble with their memory? They're having, they've been good about being able to hear and they can see fine things, kind of the facial nature of that post-op, but they're having issues with their memory.
So where the ANVS sits, first of all, so there's a lot of things that are going on, right? Once you have, whether it's you have treatment with radiation or you have surgery. But the ANVS is going to disrupt processing speed and even more so when it is removed, right? Because what happens is that in order to get to the ANVS, in order to remove it, they have to cut through some brain tissue. The surgeons have to. There's no way to get it out without cutting through at least a little bit of brain tissue. And so what winds up happening is that it's sort of like a detour must be taken, right? If your route from one part of the brain to the other part of the brain is blocked, then the message has to take a detour. And so it can take longer. And we know that if messages take longer to reach another part of the brain, then sometimes they don't have enough energy to get to where they need to go. Especially if you're within 5 months post-op is not a really long time. And so you also have what's called a neurotransmitter cascade. And so neurotransmitters are brain chemicals and they assist us with our mood, but they also assist us with things like memory. And what happens is as the brain is trying to heal itself, you can get sort of this flood, and then this sort of this flood of these neurotransmitters, and then sort of this time where things are not flowing as smoothly. And so all of these things together can make it really difficult for a person to lay down new memories. And so for these first kind of 5 or 6 months post-op, you'll probably notice that you are experiencing more difficult time, both with memory for things that you see and memory for things that you hear, especially if you're taking any pain medication, which can also disrupt your memory. And so what I will say is that for most people, after about 6 months post-op, they start seeing some little improvements. But I would encourage you to continue to do some of these things to work on your memory, some of the things that I mentioned, or if you're really concerned about it, if you continue to feel like this is a dramatic change, then I would encourage you to seek out a neuropsychological evaluation, just to kind of see where your strengths are and if you have any areas of weaknesses, because some of the things that we can do as neuropsychologists is help you find ways to use your strengths to compensate for your weaknesses. So hopefully, I hope that I want you to continue to be well on your journey. But to the author of this question, please know that you are still within what we call acute recovery stage, and you have at least another month. But I see folks who are still 2 years, 5 years post, who are still recovering from these things. And again, a lot of these things do come back. But I would be lying to you if I said that it was 100%. I tell the folks that I work with that it's think of it as sort of a pie, and that if you're having radiation or surgery, it's like you're cutting into the pie, and even if they don't take a piece of the pie out, that pie is still no longer 100% whole. And so sometimes the best that we can hope for is a 95% recovery. And so I would encourage you to think about what is a meaningful recovery for you.
Great. Is gaze stabilization separate from vestibular therapy?
It's part of it typically. So doing gaze stabilization or gaze fixation, the idea behind that is sort of, for those who aren't familiar, think about an ice skater who is spinning very quickly. And in order to do that spin and not fall down when they come out of the spin, they have to reference the same point on a wall or on the arena each time that they spin. So that's gaze fixation or gaze stabilization. And that can absolutely be a part of vestibular therapy. I think it's a very important part. It's possible that throughout here, I'm here in Central Florida, we have vision therapy here. And so vision therapy might be something that could be beneficial, but that will depend on area. I don't know about access in particular areas, but yes, typically gaze fixation, gaze stabilization is going to be a part of vestibular therapy and or vision therapy.
Great. Can you explain how oscillapsia plays into cognitive issues?
Now we're venturing a little bit outside of my expertise, but when it comes to anything that happens, when we're talking about the vestibular system and we're taking at least one ear offline, right? We're taking at least the messages that are being sent from one ear. We're taking the messages that are being sent from the parts of the inner ear, like the semicircular canals, like the otolith organs. If we're taking those, we're slowing those messages down, then the brain is going to compensate by relying on other parts of the vestibular system. And so if we can't, if the semicircular canals and the otolith organs are taking offline, then the next logical part of the brain next part of the vestibular system that the brain is going to depend on is going to be the eyes. And so anything that affects the eyes and affects, and this could be anything from nystagmus, this could be, any other, eye conditions, is going to make it very difficult for the brain to rely on the eyes to compensate for the ears. And so then it's going to have to go down to the next part of the vestibular system, which is going to be things like the cerebellum and the other parts that are going to be important for balance. So it's a great question. And it's a little bit outside of my area of expertise. So once things leave the brain, that we're getting outside of my area of expertise, but any eye condition is going to affect it. Yes.
Gotcha. You touched on this a little bit whenever you were answering the question about regaining memory and having that memory loss. And obviously, cognitive rehab timeline can look different for each person on any number of factors. But at what point might someone want to seek additional assistance or maybe kind of need to take that next step in their rehab?
So I would say it really depends on how it's impacting your quality of life. So for example, if you are really struggling to parallel park, but parallel parking is not a part of your everyday activity, then, I wouldn't necessarily refer you for a neuropsych eval. They, are sometimes covered by health insurance, sometimes not. They take a long time. And so I think it's important to consider, how much is this impacting you? Is this something that, will impact you only every now and then? And how is it impacting you emotionally? Is it something that is just a part of who you are and part of your identity? Then absolutely yes, go and get that neuropsych evaluation. I would say, it's always tough about when to say when somebody should have a neuropsych evaluation. In my ideal world, I would want somebody to have one actually before they had surgery. So we would have a pre-surgical neuropsych as a baseline. And then we would do one probably 4 to 6 weeks after surgery to have this post-surgical measurement to see, what kind of changes we're looking at. But that doesn't happen very often. So part of it's going to depend on, are you still taking pain medication? Because that can absolutely interfere with your performance. And what we don't want you to do is spend a lot of time and money when on this evaluation of your cognition, when you're taking medications that could be interfering with your cognition. So what I would say is, in terms of your recovery journey, how much is this impacting you on a day-to-day level? Are you still taking any medications that might interfere with your, the measurement, getting an accurate measurement of your current abilities? If you're no longer on medication and you're answering yes, it is impacting my day-to-day activities, then I would say at that point it's time to reach out for a neuropsych eval. Please keep in mind that there aren't that many of us in this country, and so if it's something that you're thinking about now that you might want in the future, then you may want to, it might be 3 or 4 months before somebody can get you on their schedule for testing. So I would want you to be mindful of that. If it's something where you're a couple of months out and you're really not noticing any appreciable improvement and you're starting to get concerned, call and make the appointment. And as you get closer, please don't cancel the day of or the day before. But if you're getting a couple of weeks out and you're noticing that things are better, then you can always cancel the appointment.
Absolutely. And kind of on the flip side of that, is there a point after treatment that is too late to begin therapy for cognitive issues? If it's been 10 years or so since my surgery, can I still benefit from therapy?
I would say absolutely. When we talk about recovery, we talk about the most recovery is going to happen within those first 6 to 12 months following surgery, right? But that doesn't mean that after 12 months, nothing can happen. Our brains love new information. Our brains get better. One of the reasons I went into this field is that I find the brain so fascinating because of its ability to adapt. And so, no, it's absolutely not too late. I have worked with people who are 10, 16 years out who had not heard of a neuropsychologist until they met me 10 to 16 years after their resection. So it's not too late. I would say, the other thing is that I think it's also important to remember is that, if you're 55, 60 years old when you are having this, no amount of cognitive rehab is going to make you have the brain of a 25-year-old. So I think it's also, so not only, I think it's just important that people go in with expectations that this is not going to make your brain how it was when you were 25. But, can this, the idea is to be sort of, you 2.0, right? And for you to be able to have the lifestyle back that you want, to be able to participate in the activities that you want, for me and people like me, it's all about maximizing your quality of life. And so your quality of life and what makes you happy now at 50, 55, and for the young folks out there, for the young ANs, for 28, 29, what makes you happy now, might be very different than what makes you happy in your 20s. And if you're in your 20s and this is happening, this what makes you happy in your 20s is going to be very different than in your 50s. So I guess what I'm trying to say is that I want folks to focus on, where do I want my life to go now? What do I need to be able to do to be fulfilled and to be happy? And then I want you to work with somebody that will help you accomplish that goal. But it's never too late. It's never too late to try and do something.
Great. I'll pose one here. It's not as related to this presentation, but I know it's something you've talked about in the past with some of our groups. How can patients deal with AN-related anxiety?
Oh, that's a great question. Okay, well, I think first of all, recognize that it's valid and that the anxiety is coming from a couple of different places. So if you're in, let's say you're in watch and wait, right? So right now, the ANVS is sitting on the parabrachial nucleus, which is the part of our brain that is responsible for panic attacks. So anxiety from ANVS is very much physiological, and even after the tumor is resected, you're still going to have that neurotransmitter cascade that I talked about, where you have the brain chemicals that are some of your happy chemicals that are kind of all over the place. And so you're going to have anxiety before ANVS, and it might feel like it comes out of the blue. And then you're going to have anxiety if you're in watch and wait, because of you're living in, if you're every 3 months or every 6 months, you're sort of living from scan to scan, and as you get closer to that scan, of course the anxiety is going to increase. But these are all very valid. And if you are post radiation or post surgical resection, then that tumor was growing, for most people, fairly slowly over time. And so it's not just like that you remove the tumor and everything goes back to where it was. It takes time for the brain to kind of shift back. And so again, you have now irritated the part of the brain, the parabrachial nucleus, that the tumor was sitting on top of, that is responsible for panic attacks. So if your anxiety feels like it comes out of the blue, that's the physiological part of ANVS. And for some people, medication can be helpful. For other people, mindfulness, deep breathing, relaxation training can be helpful. And then you have the sort of situational part of it, where if you're in watch and wait, of course you're going to be anxious because you're living from 3-month scan or 6-month scan. And some of you who are post-surgery are still having scans to make sure that it's not coming back. So of course there's going to be anxiety about that. So I would encourage you, again, try some mindfulness. I have a whole talk on that, so I'm going to refer you to the ANA talks on that, or to the book that I wrote, that, hopefully most of our folks, actually, I think I actually have it right here, this book, that you can also get through the ANA. There's some great tips in that. But what I would say is, if you're finding, if it feels like it's not manageable, then I would encourage you to seek out a counselor. It could be a neuropsychologist, but if not a neuropsychologist, a health psychologist or a counselor who is very well trained in working with people with chronic illness, but also recognizing that there's a lot of grief that comes along with this too. Grief and anxiety go hand in hand. I'm talking about it more in terms of grief, not depression, because we should not pathologize grief. But there is a lot of grief, changes in identity, changes in lifestyle that happen, and all of those things can contribute to anxiety. So to the author of that question, I want you to know that your anxiety is valid on multiple levels, that you are not alone. And, let's figure out a way for you to help manage this.
Great. We have a question asking, how long should somebody continue on with vestibular therapy? They give an example that they are about 7 months post-op and notice that I feel great with my balance, but if I miss 2 days in a row of walking outside, I get wobbly and trip over my feet again. So am I going to need to kind of continue that for how long?
That's a really good question. I mean, the healthcare provider in me is sort of like every day. These are things that are great to practice every day. Just getting out and walking. That's, it's good for your balance, but it's good for your mood. It's good for your cognition. And so, if you can tolerate the activity, then I would say do it every day. Do a little bit of something every day.
Absolutely. I know we've had patients before mention about finding the little things that help you with this work that you're doing every day. Don't feel like work. That doesn't feel like your vestibular therapy time. It feels like something else, and you're getting that as part of it.
Yeah, I would agree that that's your you time. Make that part of your you time, make that part of your daily practice, and think of it as maintenance.
Mhm.
Just like we have to maintain our cars, we need to maintain our bodies.
Yeah. Coming back to talking about memory a little bit, when you were talking about the different memory issues people may have and kind of the timeline of seeing that, is that the same for working memory versus long-term memory, or are those kind of involved differently?
Oh, this is a great question. Somebody has really done their homework, so thank you for that. Okay, so working memory is all right. Well, let's start with um, when information comes in to our brains. It's either going to come in through our eyes, and we call that an icon, or it's going to come in through our ears, and we call that an echo, right? And so once that information makes it into our brain, if it does, then that moment where it changes from an icon or an echo to verbal or visual attention is where we're talking about working memory. And so it's that very early. So working memory is what most people think of when they think of attention, right? Working memory is gonna, it's gonna last from, a split second to maybe 30 seconds. Um, Most of the time we kind of miscategorize short-term memory. Short-term memory is really over the course of a couple of days. And then long-term memory is going to be anything after, say, a week or so. Um, and I see this knowing full well that most neuropsychologists do all of our assessments in one day. So we're not really measuring short-term memory or long-term memory. But working memory is going to be sort of that initial the information initially comes in. And that's the part that's affected the most by ANVS in terms of auditory attention, right? Is that the echoes are not able to make it into the brain. So they're not making it into working memory. It has to go into working memory first, then short-term memory, and then be consolidated into long-term memory.
Great. Yes, somebody's definitely in tune with the memory terms and
I
that
love
side of
that.
things.
Yay, yay, yay for that author.
Talking about an ANVS diagnosis and how that affects the brain, can having heightened emotions and emotional swings be a side effect of a diagnosis as well?
Oh, absolutely. Absolutely. Yes. So if you are, and again, there's multiple levels to that. There's the physiological level because of where the ANVS is. And then there's the psychological level, right? Which is just once you hear that diagnosis. I mean, when you hear that diagnosis, even if it's benign, right? Benign doesn't necessarily mean I'm fine, right? It means, you're hearing, okay, there's a brain tumor, and you might be hearing, here are your treatment options. And if it's a certain size, then your option really is only to have it resected. But at this, all along this whole thing, as that ANVS is growing, it's displacing, other parts of the brain, right? We have a finite amount of space in our heads for the brain, in our skulls for the brain. And so as the ANVS grows, it's going to displace other parts of the brain. It's going to put pressure on the parabrachial nucleus. So you're going to have, anxiety, if not panic, full-blown panic attacks, especially if they seem like they come out of the blue. But then you're also going to have changes in your neurotransmitters, right? Your neurotransmitters, because of where that ANVS sits, they're not going to be able to get to where they need to go as efficiently. They're not going to be able to send and receive messages as efficiently. And so your mood might feel like it's all over the place, and you may not know why. That's the physiological part. But then you get this diagnosis, and of course it's anxiety provoking. I don't know a single person who has gotten that diagnosis who is just like, all right, yeah, that's fine. Most people are going to respond feeling very anxious about that, anxious about the future, anxious about the treatment. And then once you have both radiation, this happens more so with surgery, but it can also happen with radiation. Once the tumor is resected, then you're going to have, again, that neurotransmitter cascade, and it's going to feel like you have no control over your emotions. They're all over the place. And that can continue for weeks and months after surgical resection. These are not things that, that automatically recover overnight. And I think one of the most challenging parts of ANVS, particularly if you don't have facial palsy or synkinesis, is that it's an invisible illness, right? And so then other people are reacting to you without the knowledge of what you've just been through. We compare brain tumors and brain surgery. I mean, everything gets compared, right? It's the most difficult thing in the world, right? Brain surgery. We talk about brain surgery and rocket science as being the most difficult things to which everything else is compared. And you have survived that. Like, you have survived the most difficult thing that, to which all other things are compared. I think, unfortunately, again, because it tends to be more invisible, ANVS tends to be more invisible, people are not as understanding of that. And so because your processing speed has slowed down, people might get a little impatient with you. And that is only going to contribute to your emotions being all over the place. So this is a very vicious circle. So to the author of this question, yes, there are multiple layers for what are contributing to, feeling like your emotions are all over the place. Over time, the physiological part, the part that feels like it's out of the blue, will subside. But when I say over time, it might be a year, it might be 2 years until things try to even out a little bit. And that's just the physiological side. You still have the psychological side. You still have, other dealing with other people that can also contribute to that.
Yes, absolutely. We hear from many patients who talk about even years after their surgery or their radiation, or even if they're watching weight, they've kind of come to terms with it, but there's still a lot of things that can kind of set off that emotional response to it. So Dr. Sherod, thank you so much for your time. We really appreciate it. You taking time out of your day to share your expertise in this area, which is so important with the quality of life aspect. So we really appreciate it.
Well, thank you for having me, Matthew. It's always a pleasure to work with you and with the ANVS community. And I hope everyone, be well. And you have my email address if there's anything I can do to best support you.
Yes, absolutely. We'll have this posted on our website as the internet allows us, but you can also on our website see other Awareness Week presentations and also request that booklet that Dr. Sherod mentioned earlier. So thanks everyone for joining us, and have a great rest of your day.